Thank you.
It's a pleasure to be with you, at least virtually. I've been asked to discuss the impact of thyroid disease in women with infertility and those who are undergoing assisted conception. So I want to start by discussing a little bit of what we do and don't know about the effects of thyroid disorders on fertility. Then I'll talk about the effects of hypothyroidism and also of thyroid autoimmunity on the outcomes of assisted reproductive technologies. So that's basically IVF or IVF with ICSI. And then finish with a little bit of the effects of IVF on thyroid function. To start with, this is a relatively common concern. And these are recent data from the UK that suggest that of women presenting for workup for infertility, a small proportion will have overt thyroid dysfunction. So about 0.2% might have overt hypothyroidism, about 0.3% overt hyperthyroidism. Subclinical disease is more frequent. So 1.3% might have subclinical hyperthyroidism and 2.4% subclinical hypothyroidism when that's defined in the preconception setting as a TSH greater than 4.5 with normal free T4. And then the most frequent disorder that is likely to be seen in these patients is just TPO antibody positivity without thyroid dysfunction. And those antibodies are present in close to 10% of patients who present for infertility care, so probably at higher rates than is seen in the general population. So the first question is overt thyroid dysfunction associated with infertility in women? And the answer is probably yes. We don't have a lot of data for this, but the majority of the evidence supports this. It's certainly biologically plausible. And I think we all have experience with patients with overt thyroid dysfunction who present, with irregular menses, which presumably will also disrupt ovulation. So it's important to detect overt thyroid dysfunction and to treat it always before embarking on any fertility treatments. Certainly, if the thyroid dysfunction is the cause of the infertility, you may have a treatable cause, and it's possible that women won't need any infertility treatment once the thyroid dysfunction is treated. So unequivocally, levothyroxine is recommended for infertile women with overt hypothyroidism who desire pregnancy. We don't want them to be overtly hypothyroid in the preconception or the pregnancy setting. And also, we should be treating women who are overtly hyperthyroid preconception and pre-attempts at infertility therapy. What's much trickier, really, is the question of whether subclinical hypothyroidism is associated with infertility. And this really is unclear. Data that are available in the literature are really quite inconsistent, so I don't think there's a definitive answer on this. And whether or not levothyroxine improves fertility rates outside the IVF setting has never been studied. So the recommendation here comes from the 2017 American Thyroid Association pregnancy guideline, which is currently undergoing revision. And the 2017 guideline notes that there's really not enough evidence to know whether levothyroxine helps with fertility in subclinically hypothyroid, thyroid antibody negative women who are attempting natural conception, meaning not undergoing IVF. However, it's probably reasonable to consider levothyroxine in this setting, given that you might then be preventing progression to more significant hypothyroidism once somebody's pregnant. So low-dose levothyroxine is probably the right thing to do, but it's not clear whether it actually improves fertility at all. How about the effects of hypothyroidism on ART outcomes? And overt hypothyroidism hasn't been studied in the setting because, of course, it should always be treated. But subclinical hypothyroidism in women undergoing ART has been studied in a number of cohorts. These are data from a fairly recent meta-analysis that pooled 18 studies, including about 15,000 participants, and looked at likelihood of live birth after assisted reproductive therapy in women who are euthyroid compared to women with subclinical hypothyroidism. They defined subclinical hypothyroidism in different ways in this analysis. So on the left side panel, this is looking at subclinical hypothyroidism, meaning free T4 that's normal with a TSH above 2.5, probably overdiagnosing. And the right-hand panel, I think probably more appropriately using an upper limit for TSH somewhere in the range of 3 to 5. But no matter which way they slice this, there was actually no effect in this analysis of that subclinical hypothyroidism on live birth rates after ART, although I think if you look at the figure on the right, there perhaps is a little bit more of a signal of a trend in that direction with using the higher TSH cutoff. In other analyses, they looked at some other pregnancy outcomes, and the only one that really differed is that miscarriage rates seemed to be higher after assisted reproductive technology in women who were subclinically hypothyroid when that subclinical hypothyroidism was defined based on that TSH higher than 3 to 5. So if we think there's maybe at least a little bit of evidence of worse outcomes after ART in women who are subclinically hypothyroid, then the critical question is, well, if we treat those women with levothyroxine, do we actually improve the ART outcomes? Here we have only 2 very small trials. The first of those is this one. This was actually done in Egypt. And here, 70 infertile women with a history of TSH greater than 4.5, normal free T4, were randomized either to treatment with levothyroxine, titrated to keep the TSH less than 2.5, and started pre-IVF. Those women were compared to women who received placebo. And for women who became pregnant after the IVF, the levothyroxine was continued until the time of delivery. So they looked here at the outcomes of clinical pregnancy, miscarriage, and live birth rates. And they saw that the women who were treated with levothyroxine, here in light blue, had higher clinical pregnancy rates, lower miscarriage rates, higher live birth rates than the women who were untreated. So small trial suggesting a benefit of therapy. And a very similar trial was published the next year, a very similar protocol. So here, enrolling even smaller group of women, so 64 infertile women, TSH greater than 4.5 with normal free T4 at baseline, here randomized to 50 micrograms of levothyroxine daily, started at the beginning of the IVF protocol, again titrated for that same TSH target of less than 2.5, compared here to women who got no treatment. And as in the other trial, when women were treated, the treatment was continued till delivery when pregnancy ensued. So here they saw an insignificantly increased likelihood of clinical pregnancy per IVF cycle in the treated compared to the untreated women. They saw a significantly lower risk of miscarriage in the treated women and therefore higher live birth rates per cycle. So again, 2 trials that are quite small and probably really do need confirmation in larger studies, but both suggesting a benefit of therapy. So recommendations and current guidelines, the ATA says subclinically hypothyroid women who are going to undergo ART should be treated with levothyroxine. And the goal of treatment is to achieve a TSH less than 2.5. The American Society for Reproductive Medicine has another guideline, and they have fairly similar recommendations. They know that there's good evidence that levothyroxine treatment in women with a TSH greater than 4 improves ART outcomes. But really, there's not sufficient evidence right now that that's true if you initiate therapy in women where the TSH is just upper normal, 2.5 to 4. And I don't think really there is good consensus on whether those women should be treated or not. Now, a recent study that I think helps in this regard is this one. This is not a trial. This is a very large observational data set from China, 5.8 women who had serum TSH measured within 6 months prior to conception. And they looked at the associations between the preconception maternal TSH and a number of different pregnancy outcomes. And they saw for most of these outcomes U-shaped or J-shaped relationships, so that low and high maternal TSH levels preconception were associated here with higher risk for preterm delivery, for perinatal infant death, and for having children who are small for gestational age. And the best place, the sort of the sweet spot where you want that preconception TSH to be based on this study would be in kind of the lower half of the normal reference range between 0.37 and 2.5. So I don't think we can use these observational data to say that we should always treat every preconception woman to get her TSH less than 2.5. But in a woman where you've already made the commitment to treat with levothyroxine, I think it does underscore that the goal of treatment probably should be keeping that preconception TSH less than 2.5 and still in the normal range. Moving on to think a little bit about the effects of thyroid autoimmunity on ART in women who don't have thyroid dysfunction. Is thyroid autoimmunity associated with infertility? Maybe, probably. But again, evidence are not completely definitive. Limited evidence does suggest that women with infertility are more likely to have positive TPO antibodies than age-matched women who are not infertile, even when everybody examined has euthyroidism. This is a meta-analysis that's now a little bit dated back to 2016, but this looked at pooled studies that looked at the question of whether maternal TPO antibody positivity, even in euthyroid women, is associated with poorer ART outcomes. And here we're looking at the likelihood of live birth, and this pooled analysis does suggest that women with TPO antibody positivity are less likely to have live birth after ART than women who are antibody negative. So then again, that comes to the question of, should we treat these women? And the first question is, should we treat these women with levothyroxine if they're euthyroid and TPO antibody positive? Now, bear in mind, the ATA guideline was most recently published in 2017. In that guideline, based on a single small randomized clinical trial and one retrospective cohort, it was noted that levothyroxine treatment for thyroid antibody positive women prior to IVF did not appear to improve outcomes. Since the publication of that guideline, we actually have better data. So more recently, we have the publication of this trial in JAMA in 2017. This is known as POSTAL, was conducted in China. And here they screened 32,000 women pre-conception. All of these were women who were going to undergo IVF, and they were eligible for enrollment in the trial if they were euthyroid, TPO antibody positive, 40 years of age or less, and had previously undergone 2 or fewer IVF cycles. So they wound up enrolling 600 women who were randomized either to control, who got no treatment, or 300 women who were treated with low-dose levothyroxine, which was titrated for TSH goal, initiated pre-conception, and if pregnancy occurred, continued until delivery. They looked as outcomes here at miscarriage, at clinical pregnancy rate, at live birth rate, and saw no difference in any of these parameters. So this was a pretty resoundingly negative trial, which was followed up a couple of years later by this trial. This is known as TABLET, conducted in the UK and published in the New England Journal of Medicine in 2019. So this had a somewhat similar trial design. They screened 20,000 women here either with a history of infertility who were going to undergo IVF, or also women with a history of miscarriage. So important to note that some of the women in this trial wound up conceiving naturally, and some of these women wound up conceiving with ART. They were eligible for enrollment if they were euthyroid and TPO antibody positive. 476 women randomized to placebo, 476 women randomized to treatment with fixed dose levothyroxine, 50 micrograms a day, and again, initiated preconception and continued until the time of delivery if the woman became pregnant. The primary outcome in this trial was live birth at least 34 weeks gestation, and again, they saw no difference. So a negative trial. They also saw no difference in rates of miscarriage, in preterm delivery, and in any of the neonatal outcomes they looked at. So now we have 2 fairly negative trials in this space, which I think were well conducted. In 2017, the guidelines said, at that point, based on the evidence we had, there was insufficient evidence to conclusively determine whether levothyroxine improved success after ART in TPO antibody positive euthyroid women. We suggested considering treatment in those women, but I think in light of the subsequent negative trials, that is clearly going to have to be reconsidered as the guidelines are revised, and this is not something I am doing any longer in my own clinical practice. The other intervention that has been studied preconception in women who are TPO antibody positive but euthyroid is the use of glucocorticoid therapy. And here we have 2 very tiny trials. So data that I think are really not conclusive. The first trial to look at this is this one. So they randomized 60 euthyroid women, here TSH less than 2.5, who were TPO and or thyroglobulin antibody positive and who were going to undergo IVF. They were randomized to either prednisolone, 5 milligrams a day, starting at the time of oocyte retrieval and continued to the end of the first trimester, compared to women who got no treatment. And they looked here at the same outcomes that all these studies look at, clinical pregnancy rate, live birth rate, miscarriage rate. And what they saw in this trial was the prednisolone-treated group here in blue had higher rates of clinical pregnancy compared to the controls. They had non-significantly higher live birth rates and no difference in miscarriage rates. So sort of a mixed picture here in a very small trial, but possibly some suggestion of benefit. The other trial is even smaller. It's an N of only 48 women. And these were women who had a history of infertility, who were treated not with IVF, but intrauterine insemination, or IUI. So these women, again, euthyroid TPO antibody positive. Here, the glucocorticoid regimen was 10 milligrams of prednisone a day that was started 4 weeks before the IUI and then tapered gradually and sort of stopped at the time of the IUI treatment, compared to women who received placebo in the setting of the run-up to the IUI. Here they looked at miscarriage rates and pregnancy rates. Pregnancy rates were actually higher in the women who got the prednisone compared to the women who got placebo. The miscarriage rates were also higher, although not significantly so. And again, very, very small numbers enrolled in the study, so hard to make conclusive determinations. It's also notable that we have a reasonable amount of literature looking at safety of glucocorticoids in late pregnancy when there are often indications for using them. There's actually not a lot of safety data in the literature for use of glucocorticoids throughout pregnancy or particularly in early gestation. And looking at the totality of the evidence, which really has not shifted since the time that the 2017 guideline was published, we had looked at the data and recommended specifically against the use of glucocorticoids in euthyroid thyroid autoantibody positive women who are undergoing ART. I don't think this is typically used in the US where I practice, but I recognize that there are parts of the world where this is more frequently employed. And I think myself that it's sort of interesting and potentially worth additional study, but I don't think it's really ready for clinical practice. So flipping things a little bit and thinking not about the effects of thyroid on ART, but the effects of the ART treatment itself on the thyroid, important to note that we're doing a lot of hormonal manipulation in these women for these controlled ovarian hyperstimulation regimens. Typically, there are a number of different ways to do this, but typically there's some kind of gonadotropin that's given in the run-up to allow the development of a number of oocytes. And then when, based on ultrasound, it looks like these sort of eggs are close to maturation, a woman is given a dose of HCG to sort of fully mature those oocytes prior to retrieval. And it's important to note that these hormonal regimens will tend to cause a big spike in estradiol, particularly the HCG causes that big spike in estradiol, so that women have estrogen levels circulating, initially after the egg retrieval that are very similar to estrogen levels in late pregnancy. So they spike very high very quickly. And that spike in estrogen will drive an increase in thyroxine binding globulin that will be transient if a woman doesn't become pregnant. But if she then subsequently becomes pregnant, pregnancy itself will tend to start a rise in estrogen also, and the TBG levels continue to climb. It will also trigger usually just a slight increase in serum TSHs around the time of that HCG stimulation, which is usually pretty mild and pretty transient, but which then seems to kind of stimulate an increase in free T4 production. And again, if pregnancy ensues in a normal physiologic pregnancy, the free T4 will then continue to climb during the first trimester. We don't see these expected changes in women who are TPO antibody positive, and we may not see them in women who are getting exogenous thyroid hormone replacement. So in women who are TPO antibody positive, we think perhaps there's already a little bit of underlying thyroid compromise, and they don't necessarily respond to the HCG the way a normal thyroid would. So often in the TPO antibody positive women, you see not just a slight bump in TSH, but you see a real increase in TSH. In response to the IVF hormonal protocols, and that may stay elevated. And you may see real declines in free T4 in those patients. And in the patients who are treated with fixed dose of levothyroxine, well, based on increased deiodinase activity, you get slightly faster metabolism of thyroid hormone. that's being given exogenously, and then the higher TBG levels, which kind of soak up all that hormone, you see potentially, again, slightly more of a TSH increase. But in all pregnancies, as soon as we know a patient's pregnant, we should be increasing the levothyroxine dose by 25 to 30%. And typically, if you know these women are pregnant right away because they get the pregnancy testing after their IVF procedures, and one would just increase the levothyroxine dose as soon as the pregnancy test is positive, which is the same thing we do outside the IVF setting. And those women tend to do very well. And in general, if you can avoid checking thyroid function tests in the immediate 2 weeks after egg retrieval, it's better because it can sometimes be a little bit hard to interpret these numbers. So I conclude by noting that there's, I think, good consensus among obstetricians, reproductive medicine experts, endocrinologists, that any woman who's presenting for workup and treatment for infertility should have screening for thyroid dysfunction. And unequivocally, if we identify overt thyroid dysfunction, that should always be treated optimally pre-conception. It does not appear right now that there's any benefit of treating euthyroid TPO antibody positive women, but because, as I've shown you, those women are at risk for developing hypothyroidism as pregnancy progresses or as a result of ART protocols, those are women who should be monitored fairly closely in pregnancy, and levothyroxine should be initiated if those women do become hypothyroid. So this is an algorithm published in a recent review, which I think is actually quite nice, again, suggesting, I think, a pretty reasonable approach. So in somebody preconception who's going to undergo IVF, if the TSH is greater than 4, I think it's reasonable to start low-dose levothyroxine, do that 6 weeks prior to the ovarian stimulation, ART procedures, so that you know you've normalized thyroid hormone levels before, and then follow those patients' thyroid function every 4 weeks in early gestation, as we would in any patient we're treating with levothyroxine. Women who are TPO antibody negative, normal thyroid function, obviously don't need any thyroid treatment before IVF. And women who are thyroid antibody positive, I think in light of current evidence, should not get levothyroxine and should not get glucocorticoids, but should have follow-up of their thyroid function every 4 weeks in early gestation with treatment if they become hypothyroid. And then women who are subclinically hyperthyroid preconception, I haven't talked about them, but we don't think those women require treatment. We typically would just monitor. And women who are overtly hyperthyroid prior to pregnancy do deserve treatment, either with antithyroid drugs or with definitive therapy, with surgery or radioactive iodine to ensure euthyroidism before they try to conceive. So with that, I thank you for your attention.